a case of improved essential tremor using deep brain stimulation after failed high-intensity focused ultrasound. I wanted to briefly kind of talk about defining essential tremor and how you assess it in the clinical setting. So, essential tremor, it presents as a postural and kinetic tremor, and what that means is that a postural tremor would be a tremor that is a position, or it's when you're holding a position against gravity. So, a common one that you'll see is you'll have a patient stick their arms out like this, and then you see if they have a tremor. Um, Another tremor you may want to see is a kinetic tremor, which presents when the patient attempts voluntary movement. So many of us might see this in elderly family members that have essential tremor. They may be reaching for something at the dining table, and you can see their hands shaking. So that is something that would be a kinetic tremor. So those are the most common, but patients do often present with other tremors. Our patient, as we're going to talk about, did have a voice tremor as well. So you may see shakiness when they're talking. Um, when a patient has essential tremor, oftentimes this can have an associated alcohol use issue as well as anxiety around the tremor, especially in social settings. Patients may want to drink a little bit in social settings so that they can quell the tremor. And I will talk about the kind of possible physiology behind that in a second. Um, so tremor is clinically diagnosed, and you really want to exclude other causes of tremor because there are some other conditions that are more severe and you don't want to miss. So, and then you could use testing to assess the severity of the tremor. So, what is the leading theory behind what's causing essential tremor in patients? Well, it's not currently fully known, but the involvement of alcohol in quelling the tremor does suggest a possible interesting theory in that there may be involvement of the inferior olivary nucleus. So the inferior olivary nucleus is the section of the brainstem. It is that kind of squiggly line portion that you may see there, and it's thought to kind of work in sort of fixing and providing corrective input to movement and proprioception. So there is possibly some involvement of the inferior olivary nucleus. There are maybe some familial associations in essential tremor. There is an autosomal dominant form, but it has reduced penetrance, which means that there are some people that may not have a tremor despite technically having the condition passed down. There's also a sporadic form. So, what are physicians going to look for when they're working up a possible case of essential tremor? So, really, what they're going to assess is they really want to do a detailed history, and this is going to include medications, a family history, and a psychosocial history. Psychosocial history may be more to see how it's affecting the patient in social situations, and again, like if it's providing any anxiety and what they might do to self-medicate for the tremor, such as using alcohol. Depending on the patient, you might want to do some labs to assess for the tremor and anything that's causing the tremor. So an example would be checking a serum copper if you have a clinical suspicion of Wilson disease. That can also cause a tremor, and that's definitely a condition that is treatable, but you would want to catch it early before it starts to cause permanent issues at the brain and liver. You may also want to check for routine labs, just depending on what the patient's presenting with and what their history is. The medications are also important, as we'll talk about in a second. Um, there are some ways that people can get tremors just based on the medications they're taking, or maybe even caffeine that they're taking in. There are also tools to assess the severity of the tremor. So common ones, I'll talk about the TETRAS in a second when we discuss the patient, but you might even have the patient sign their name and see how they're able to sign their name. With this patient, he was having a lot of difficulty even producing a semi-legible signature. And then the Archimedes spiral, I'll also show in a minute, is having the patient draw a spiral on a paper and seeing how much variation there is in the line there. Normally, people can produce a pretty straight line on that spiral, but people with essential tremor and Parkinson's disease, they have a lot of wiggliness in that spiral that they do. And you can even have them do some general tasks of daily living. Something you might see a neurologist do is have a patient try to even drink a glass of water, especially with essential tremor, since it is a kinetic tremor. They'll be trying to drink a glass of water and it'll just be shaking and spilling all over them. And it can cause a lot of issues at home and in social situations. So kind of figuring out how you're going to treat it and approach it is really important. So let's look at a couple of other things that the physician might want to rule out before officially diagnosing essential tremor, as it is a diagnosis of exclusion. So, the differential, you really want to exclude an enhanced physiologic tremor, just maybe even caused by the patient drinking too much caffeine. Some people may have noticed that when they drink a lot of caffeine, they start to feel their hands shake a little bit, and that can cause it. And if it causes the patient enough distress, they might have even gone to a physician to talk about it, despite it just being caused by the caffeine intake. Parkinson's disease is also another one that you want to rule out, as the treatment is drastically different between true essential tremor and Parkinson's disease. A seasoned neurologist probably wouldn't have too much difficulty differentiating between Parkinson's disease and essential tremor, but it is something that they do want to make sure they rule out, as severe cases of Parkinson's disease may present similarly. There are some other conditions too, hepatic failure, as we discussed before, Wilson's failure, or Wilson's disease, are some conditions that can cause tremor, and those also have a different treatment than essential tremor does. And imaging is not usually necessary for diagnosis, but that's really up to the neurologist depending on what the clinical picture is. So let's say we've decided that a patient has essential tremor, and how are we going to approach the treatment? So this is a pretty well-described algorithm. Generally, they do generally follow this algorithm, and usually it's going to be propranolol that they start with unless there are some contraindications. That's going to be why it's really important to assess medication history, because some of these medications do have some big contraindications depending on the patient's medication history or their medical history in general. So propranolol is a beta blocker. There's a theory behind why it works, and that is that it might be reducing some sympathetic stimulus to the muscles that are causing them to shake. Primidone is an anti-epileptic that is another first-line medication. As you can see on the chart, there are certain patient comorbidities or factors that might determine whether you're going to use propranolol or primidone. And then if those fail, or let's say the patient has been on it for a while, you're going to try one of the second-line medications, which you could do a combination of the two. You might move to topiramate, and then you may even go for benzodiazepines. Those do have a lot of side effects, and patients might not want to be on them. So propranolol and primidone do generally work very well, but over time, patients may progress and they might need more. So what do we do in that case when the patient does progress and needs something besides those medications after you've already exhausted your medical options? Well, they do have some other options, and that's what the focus of this presentation is. Botulinum injection is one that is more recently being evaluated, and it is a pretty cool way of treating essential tremor that they're now sort of working up. As you can see in the picture, some clinicians have been assessing the kinetics involved in certain patients' tremors, and then they're seeing which specific muscles are causing the issue and which areas are causing the biggest issue. That way they can inject those areas with Botox and cause kind of a minimal paralysis without affecting the patient function too much. But really the main thing we're going to talk about is deep brain stimulation and high intensity focused ultrasound. So let's go ahead and talk about those. So let's talk about the patient. He's a 75-year-old male. He was previously assessed and treated for essential tremor. He's received high intensity focused ultrasound, and he did fail his medical treatment prior to that and was using alcohol pretty heavily to attempt to quell the tremor. The high intensity focused ultrasound initially improved the tremor, but after about 3 years, he started to regress again, eventually getting to the point where he was essentially at his starting point or even worse than that. So what they originally did was high intensity focused ultrasound to the VIM nucleus of the left thalamus. And you can see in that picture, the white hyperintensity area with the arrow pointing to it is where the ablation was done. So we assessed him using the TETRAS scale, which is a two-point scale that assesses for activities of daily living. This kind of has to do with occupational movements and just general things that somebody might be doing, just walking around at home or living their life. And then The performance subscale is a more specific scale that's assessing things like a head tremor and a voice tremor and an extremity tremor. So he scored pretty highly on those ones, especially the activities of daily living. He was then evaluated by a DBS committee and approved for DBS to the bilateral VIM nuclei of both thalami. So what were the results? Well, the device was programmed 1 month later, as is typically done with DBS surgeries, and there was a significant improvement in his tremors. So here are his Archimedes spirals before and after. Before, you can see that he was really having a lot of trouble staying within the line. He even crosses over the line at some points, especially on his right hand, which seemed to have had a worse tremor. You can see after a month, even with the DBS device off, the Archimedes spirals are a lot more clean. And then when the device is turned on, it's almost as if he never had essential tremor in the first place. Unfortunately, the patient did sustain an injury to his cervical spine soon afterwards, and it did complicate his follow-up assessment. But his improvements there were really impressive and were sort of unexpected. So not necessarily unexpected, but they were a lot heavier of an improvement than one might think there would be. So his results, he did end up returning to clinic after his injury was handled. And since then, he's required minimal reprogramming of his DBS device, and he's just been undergoing maintenance to sustain his results. So that kind of paints a big picture of why patients might want to choose DBS. The ability to reprogram the device really does pose an advantage as far as fine-tuning the device and what it can do to better meet the patient's needs. So let's briefly discuss the two big procedural options and why a patient and physician might decide to choose one or the other. So high-intensity focused ultrasound was approved more recently for treatment of essential tremor, but it's been used previously for cancer ablation and is still used, especially for prostate cancer. The big benefits is that it's a non-invasive option, so patients sit on a table for a couple of hours while they deliver the ultrasound beam, and it does show really good improvement in over 90% of cases. 5 years later, the results generally remain the same. So it is a non-invasive procedure that is fast, but it does have some limitations. One of the biggest current ones is that they can't do a bilateral ultrasound in the same procedure. They do have to wait 9 months in between the first one and the second one. DBS has been the long-time procedural option since even the late 90s. It's used in a lot of other conditions such as Parkinson's, and now they're even evaluating it for use in epilepsy. But it does provide significant improvement in patients. It is programmable, which is also nice, as we talked about before, but it comes with the typical risks associated with neurological surgeries, especially infection or maybe even surgeon error. But generally, the surgeons doing DBS are very well seasoned and experienced. So let's talk about why essential tremor research and elucidating these things is pretty important. So essential tremor affects as much as 2.6% of the US population, which is a pretty significant amount. And there can be associated health concerns. So there's obvious potential for injury when the patients aren't making as precise of movements. They might not be able to do the movements as they intend, and they can risk injuring themselves. There's also the risk of social anxiety and even isolation because they don't want to go out and meet with friends and family because they're embarrassed of their tremor. And then there's the potential for dependence on alcohol as patients try to quell the tremor when they feel their medications aren't working. So further research on essential tremor is important. The procedural options are becoming more advanced, and evaluating what we might want to do for patients when they fail one or the other is going to be of paramount importance as patients begin to rely more on procedural options. So we might want to look at the effects on the brain and contraindications. And the contraindication typically of doing DBS is if they've had, or even high intensity focused ultrasound, if they've had a previous ablative therapy, but there may be some wiggle room. So there is a minimal framework on cases such as this, and evaluating what we might want to do from there could be more important as patients might present more with procedural failures. So here are my citations, and thank you for listening.